What's up, guys? Tyler here from FOAMfrat, and I came across a really cool paper that I wanted to show you guys. This paper looks at rate control for patients who are in septic shock. And I think we've all seen those patients where they're on Levophed or Epi and Vaso, and their heart rate's like 130, 140, maybe 150, and you're wondering, would there be any benefit to lowering that heart rate? And I've always wondered why we don't use Esmolol in those situations, because when you lower the heart rate, you're hoping that you buy more cardiac output. And so you're saying, all right, I'm going to increase diastolic filling by slowing down the heart rate, and hopefully that will give you more cardiac output and more stroke volume, but it doesn't always. And so you're directly dropping heart rate in hopes that you're going to indirectly improve cardiac output. Sometimes it doesn't happen. And so Esmolol makes a lot of sense to me because it's something that you could turn off if reducing heart rate does not increase cardiac output. And so I started digging around a little bit for a talk I give in the FOAMfrat refresher, and I found this paper that was published in JAMA in 2013, and it was the effect of heart rate control with Esmolol on hemodynamic and clinical outcomes in patients with septic shock, and it was an RCT. So here's what they did. They had 154 patients who, after 24 hours of resuscitation, still had a heart rate greater than 95 beats per minute. And so they had two arms. There was the control arm, and those patients got all the normal stuff. They were still on Levophed, they were still on Epi, pressors, fluid. The only thing they changed in the intervention group is they gave them Esmolol. And so they would provide them Esmolol to try to control their heart rate. And so what they wanted to see is if they could, for one, maintain the heart rate between 80 and 94. That's a very specific parameter, but they were able to do that in the Esmolol group, and the control group, they were not able to. Those patients had a higher heart rate. And that makes sense with a lot of the catecholamines that we're giving just for the pressor response. The next thing was, did they have a decreased pressor response? So if I drop the heart rate down a little bit, increase diastolic filling, does that decrease my need for pressors? And it did in the Esmolol group compared to the control group where it did not. And then the last one was fluid requirements. So if my heart's beating slower, it's got more time to fill, and hopefully it increases stroke volume and cardiac output, are those patients going to need less volume, less fluid? And that was true in the Esmolol group, and it was not true in the control group. Now, there were some secondary outcomes like 28-day mortality, ICU mortality, and hospital mortality, and Esmolol came on top with all of these as well. So Esmolol is not typically a drug that you think of for controlling rate in septic shock, but it may be beneficial because you can pull it off if that cardiac output doesn't improve. Now, I traced along their graph, and you can see how well the Esmolol kept that heart rate controlled between that tight parameter that we looked at. And so you can see after 24 hours, remember they got that volume, and that's really important that they were resuscitated for 24 hours before Esmolol was started. So you come across a patient in the field and you think, oh, I wonder if this patient in AFib RVR or whatever it would benefit from Esmolol. Keep in mind the study resuscitated them up to 24 hours. Then they started the intervention. That's when they were given that Esmolol. And that's really important because I call these types of studies booger studies because you can pick them up, but you don't know what to do with it. And so this is how I think of it. So sepsis rate control. Let's say you go to a patient, their heart rate is greater than 100, their MAP is less than 65, and it's early on in their septic course. And when I say early on, I mean you're picking up a patient from a nursing home or you're picking up a patient from their home that you think is septic. I'm going to be a little bit hesitant to even consider rate control. At that point, you need to just imagine that they are compensating for their hypotension. But 24 hours post-resus, you're taking a patient out of an ICU who's been there for some time and their heart rate's cruising along at 150. Let's say the heart rate's up, the blood pressure could be up or down. That is a time where you may consider talking to the referring physician, the receiving physician, and seeing what their thoughts are on something like Esmolol, where if it doesn't work out and their cardiac output drops when you start to reduce that heart rate, using an agent that you can pull off like Esmolol, as opposed to something like diltiazem and amiodarone. So I found this study super helpful. I thought it was really cool. If you guys are interested in learning more about this, you can join me in my class next month on AFib RVR as an innocent bystander, and we'll talk to you guys soon.